Hello, I am Jolie Long with the National Board for Certified Counselors. On behalf of the Medicare Mental Health Workforce Coalition, we would like to welcome you to our webinar today. Next. Before we begin, I would like to share some meeting details. Closed captions are now enabled and attendees can turn these on and off as desired. Interpreters can join the meeting via the phone number, ID, and passcode provided on this slide. A link to this PowerPoint presentation will be posted in the chat so you can access the links on the slide. To receive continuing education credit, you must complete the session evaluation, including an attendance attestation. The link to the evaluation will be posted in the chat at the conclusion of the webinar. We will also send you an email with a link to the evaluation following the webinar. We will only be providing continuing education for live attendance. This webinar will be recorded and made available on the NBCC website and other coalition member websites for viewing purposes only. Due to the large number of attendees, the participants will remain in listen-only mode throughout the meeting. The presenters will be taking questions at the end of the session, so please feel free to type your questions into the Q&A box at any time. Next. This is the 16th Medicare webinar that the Medicare Mental Health Workforce Coalition has produced. Please find information on videos of the previous presentations via the link on this slide. Next. The Medicare Mental Health Workforce Coalition consists of organizations that collectively represent providers, clients, patients, and other stakeholders. Our overall mission is to increase access to client choice for mental health provider care. Together, we achieve this goal with the passage of the Mental Health Access Improvement Act. The coalition is now working to ensure successful integration of counselors and marriage and family therapists into the Medicare program, and we're providing clinical educational resources to work with Medicare clients. The coalition members are listed on this slide. Please note that we recently welcomed the National Association of Social Workers as a new coalition member. Next. Today's webinar is titled Late Life Suicide Prevention from Assessment to Intervention. The learning objectives are listed on this slide. We welcome Dr. Kim Van Orden of the Department of Psychiatry at the University of Rochester Medical Center. She will be followed by a marriage and family therapist and a mental health counselor who will share their reactions to Dr. Van Orden's presentation and talk about MFTs and counselors' training in their work in the field on this topic. I would now like to introduce our speakers. Their full bios are in the slides for your convenience. Next. Dr. Kim Van Orden is an associate professor in the Department of Psychiatry at the University of Rochester Medical Center. At URMC, Dr. Van Orden is the co-director of the Center for the Study and Prevention of Suicide, which is one of only a few research centers around the world which focuses on suicide. And she is the director of the postdoctoral training in suicide prevention research. Her work mainly focuses on suicide prevention, injury prevention, and suicidal ideation. She also directs the HOPE, which is Helping Older People Engage Lab, which focuses on developing and testing interventions to increase connectedness. Next. Dr. Jordan Westcott is a counselor educator and a national certified counselor focused on how communities access mental health care and their unique mental health needs, with emphasis on older adulthood, LGBTQ+ identity, and intersections therewithin. Her research, teaching, and service focus on the needs of marginalized communities in the context of counseling, with an emphasis on how counselors can be change agents. Dr. Westcott is an assistant professor of counselor education in the Counseling, Human Development, and Family Science Department at the University of Tennessee, Knoxville. Next. Dr. Kat Hertlein is a professor in the Department of Psychiatry and Associate Dean of Faculty Affairs and Professional Development in the Boonshoff School of Medicine at Wright State University in Dayton, Ohio. She was previously a professor and program director of the Couple and Family Therapy program at the University of Nevada, Las Vegas. She received her master's degree in marriage and family therapy from Purdue University, Calumet, and her doctorate in human development with a specialization in marriage and family therapy from Virginia Tech. I now welcome Dr. Van Orden to begin her presentation.
Wonderful. Thank you so much. So I'm excited to be here today to tell you about late life suicide prevention and hopefully provide you with some information to help you feel comfortable working with older clients who may be experiencing suicidal ideation. Next slide, please. I do not have any financial disclosures. I do want to acknowledge my gratitude for some funding I have from the NIH right now that supports some of the work that I will tell you about. Next slide, please. And one of the things that I want to start with is telling you just briefly about the E4 Center for Excellence for Behavioral Health Disparities in Aging. And that is because the E4 Center is why I'm able to be with you here today, because I am part of their work and they connected me with this wonderful group. So I wanted to acknowledge them, their great work, and also let you know about some of the resources they have to offer. So they're a national center based at Rush University, and they're dedicated to training clinicians with a focus on the areas you see in that Venn diagram. And you'll see that suicide prevention is on there. And today, throughout my talk today, my colleagues will be putting some links in the chat for you with resources you may find useful. I like to do that because I know some of the topics we'll be talking about can raise some of our anxiety. And so I want you to know as we're going along that there's many more resources for you to learn more and dive deeper into topics we discussed today. And the E4 Center in particular has some wonderful resources that may be useful for you in terms of learning more about this. So next slide, please. So the E4 Center has a lot of resources, and they focus on supporting the mental health workforce and gaining comfort and confidence in working with older people. So there are a lot of resources. They have resource booklets that you can download. They have online training as well. So next slide, please. They have a webinar series that you may enjoy and benefit from. Here are two of the upcoming presentations that they'll have, including one on ageism. They have a series on evidence-based practice, and so there's a link in the chat for you about the calendar, and you can sign up for some of those talks. Next slide, please. Another talk that may be of interest is if you are newer to working with older people, the 4 M's of behavioral health care. That's an excellent presentation that will be coming up soon and will be kind of an ongoing learning series. Next slide, please. And then the final one that I want to tell you about is the E4 Center has a foundational competencies in older mental health online certificate program. If you just want to learn, it's free. If you'd like some continuing education, it's very low cost and super high quality training. Next slide, please. Okay, so before we dive into the nitty-gritty of all that we're going to talk about, I want to start with really the most important thing that I'd like for you to take away, if you forget everything else that I talked about, which is the idea that there's actually a very large body of literature that just demonstrates that later life is most often a time of improved emotional well-being. So I hear from my patients quite a lot things like, of course I'm suicidal, of course I'm depressed, I'm old. But actually, one thing that we need to keep in mind as clinicians working with older people is that that's not true. The normative developmental pathway as we age is actually towards greater emotional well-being. Later life is not a time of despair and loneliness. Most older people experience better mental health and greater well-being than at earlier points in their lives. And at the same time, we are talking about suicide prevention in later life today. And that's because those who do get off track developmentally do struggle significantly. And so that makes later life a time of both risk and resilience. And so the task that all of us fortunate enough to be able to work with older people, the task that we have is to help guide them towards the path of resilience. So next slide, please. So I'm going to start with just a little bit of information about the epidemiology of suicide, just what we need to know to be on the same page to really take the rest of the material and use it to the best of our ability. So next slide, please. So here's my epidemiology slide. I'm going to tell you what I want you to take away from it. So first of all, older adults are the most rapidly growing segment of the population. Call that population aging. There'll be more and more older people who need us to work with them. We also know that suicide rates increase with age around the world. That is sometimes surprising to folks because in the media, we hear about young people, and it's absolutely a tragedy when young people die by suicide. At the same time, the greatest rates are among older people. And in the US in particular, that tends to be older white men. And so what you're seeing in this graph is data from the CDC. And on the y-axis, you're seeing deaths per 100,000. So higher means a higher rate. On the x-axis, we have men and women split apart. And so one thing that will pop out at you is that men have the highest rates. So women are more likely to attempt suicide. Men are more likely to die when they attempt suicide. The other thing you're going to see in that are the different color bars. Those are reflecting ages. So here we just have midlife and later. And so what you'll see, the bar that really pops out is that light green for men, and that's men 85 and older. In the US, men 85 and older have the highest suicide rate of any group. And so they need a lot of our attention and a lot of our support. So the final bullet point on that slide is that in successive cohorts, the problem may actually increase. There's some data showing that different cohorts or generations kind of carry with them an average suicide risk or rate, and they carry that with them through points of higher risk. So we are seeing that the baby boomer cohort brought in kind of a higher rate, and subsequent generations have seen similar or higher rates. So all this to say, I am so glad that all of you are here today because we're going to need more and more of us working together on this problem and to help our older people. So next slide, please. Okay, so the other piece that I want to highlight is that suicidal behavior is more lethal in later life. And what we mean by that is that when people engage in suicidal behavior, so not everyone who has thoughts will act on them, in later life, when people act on the thoughts, it's more likely to result in death. Why is that the case? Well, older people tend to be more planful and determined. And in the United States, that tends to mean a means of firearms, so using firearms. They're also less likely to be rescued and more frail. And so there's a lot on the graph, but really all I need you to take away from it is that the bars on the left for firearms, you see that the using firearms gets more and more common with age. So firearms are an increasingly important thing to consider when you are working with older people. And so this can be kind of a frightening thing to think about as you're getting into working with older people. So I want you to know that we are going to have more resources in this that I have at the end for you. And there are also additional resources to learn more about how to work with older people around dealing with firearms. And so I have some links that I believe my colleagues are going to put in the chat for you now. One is firearmlifeplan.org, and that's a really nice resource that talks about managing firearms in a really non-judgmental way. It's not about taking people's guns away from them. It's about being thoughtful, working with your patients or your clients to partner with them to think about how they want to make sure their firearms are handled after they're gone, but also if they were to become ill, things like that. And so it's a really nice way to have an open conversation about safety around firearms. And that's focus on older people specifically, so thinking about things like not just suicide, but dementia. having grandkids in the home. So that can be a great resource. The other resource I have for you is suicide specific, and that's Means Matter. And there's a lot of information in there about lethal means counseling. If you want to learn more about that, have kind of some useful words to use with your patients. Okay, so next slide, please. So placing the work that we do with our patients in counseling in kind of a larger picture, optimal suicide prevention for older people will include a whole lot more than just what we're able to provide in a weekly session. Because suicidal behavior is more lethal in later life, we want to be as aggressive as possible in terms of our interventions, meaning doing as much as we can to make sure that older people are getting all the care that they need, as well as including more distal prevention. So not putting all of this on you as counselors, but keeping in mind where your work will sit in a larger mosaic of what we really need to prevent suicide in later life. So we need detecting and treating depression, but we also need programs that back up from a suicidal crisis. Selective interventions where we're helping to optimize independent functioning, increase social connectedness. And we also need universal interventions, meaning things that target our whole population, helping people understand the role that ageism can play in suicide risk, and health for all of us, education to reduce ageism, things like promoting firearm safety. Those are part of the overall mosaic of things we need to reduce suicide risk in later life. Next slide, please. All right, so the 5 dimensions of suicide risk for suicide risk in later life. This is a model I call the 5 Ds that I collaborated with my longtime mentor and colleague, Dr. Yates Conwell, who is a geriatric psychiatrist. We collaborated on this model to make it hopefully a little bit easier to remember the characteristics of suicide risk in later life and also to think about interventions for them. So the 5 Ds is the idea is that there's a whole lot of research showing us what older people who die by suicide, what are their characteristics. So this came from work that Dr. Conwell did, pioneering work on psychological autopsies in later life, when they were able to talk with the family members and friends, next of kin of individuals who died by suicide and understand what was going on in their lives. And they found these 5 dimensions, or Ds, characterized most of the people who died by suicide. And so I'm going to go through each of them in a little bit of detail to highlight for you what they look like. And so all of them begin with D. So we've got depression, diseases, access to deadly means, firearms, social disconnection, and disability. And you can see with the Venn diagram, the idea is that when they all start to pile up and a given individual has more and more of these, their risk is going to increase. So compounding risk. Next slide, please. So I'm going to go through each of those 5 Ds with a little bit of detail so that you can kind of understand or bring that picture alive. So depression and suicide, what we know. So mood disorders, especially major depression, are common among older adults who die by suicide, and the proportion of those who die by suicide in later life who have depression is likely even larger than at younger ages. At the same time, few will have received formal psychiatric diagnoses or treatment. And also, the combination of depressive disorders and comorbid medical illness is particularly common in later life. If you don't know much about how depression looks in older people, some of the resources from the E4 Center may be really great to follow up with. I'll give you a brief preview. So depression in later life, older people are less likely to report sad or depressed mood, and more likely to report anhedonia, or things like apathy, as well as cognitive complaints like problems with memory or concentration, executive functioning. They might talk about somatic symptoms like sleep, fatigue, or psychomotor slowing as their primary presenting concerns. Next slide, please. What we know about in terms of the second D. So this is disease, so physical illness, what we know. So older people who die by suicide are characterized by a sharp decline in their physical health in the year before their death, multimorbidity. So what that means is not just one illness, but multiple piling up. And as the number of chronic diseases increases, so does suicide risk. Poor sleep quality is a big one. Older people who die by suicide are commonly seen in primary care. So, one takeaway from that is collaborating with primary care patients is really important for our older people at risk for suicide. And finally, as I mentioned, the combination of a depressive disorder and a physical illness is very common. Next slide, please. So, what we don't know yet, sometimes it's as important to talk about what we don't know as it is what we do know. So, there's lots of inconsistency as to which specific diseases or organ systems are most strongly associated with suicide in later life. As well, to make things more complicated, some illnesses may be associated with increased risk for thinking about suicide, others with attempts or deaths. There are numerous possible mechanisms whereby physical illness may increase risk for suicide in later life, including neurobiology of stress, neurobiology of illness, and functional impairment. So the reason I tell you this is that you don't need to be, in my view, on the lookout for a specific disease or illness. Instead, what can be more helpful based on what we know now is thinking about multimorbidity. So when people have more and more illnesses, that's when we may be concerned or want to think about that as an issue to think about in our interventions. So next slide, please. So disability. So this is our third D. Disability can also be referred to as functional impairment. And this is linked to suicide ideation, attempts, and deaths in older people. We know this through psychological autopsy studies, but also observational longitudinal studies that follow people over time. If you're newer to working with older people, we think about two types of functional impairment or disability: the instrumental activities of daily living, or IADLs, and the activities of daily living, ADLs. Both are linked to suicide risk. The instrumental ones are the things that are a little sort of more advanced skills in terms of things like being able to manage finances, things like that. You might lose these first. So ability to manage your groceries, your finances, all of that kind of stuff. The activities of daily living are more basic living skills like being able to bathe or toilet or manage your clothing. So both are very important, as well as sensory impairment. So that includes vision loss, hearing loss. Those are all really key things to keep in mind in terms of characteristics of older people who die by suicide. Now you may be thinking, Kim, well, wait a second. Those are all really common in later life. And yes, they are. The trickiest thing about suicide prevention is that all of our risk factors are really, really common, and suicide is thankfully very, very rare. So your goal in understanding the clinical picture of your patients for suicide risk isn't necessarily, or isn't, to predict if they will die by suicide. Instead, it's to identify the most relevant and malleable factors driving their suicide risk so that you can help reduce their suffering and reduce their risk. So next slide, please. So more about what we know about disability or functional impairment. While most aren't going to die by suicide who have this, because disability is very common, there are some presentations that are most risky, or when you might be most concerned or most likely want to target disability as part of, say, your safety plans. So individuals who need assistance with ADLs, that would be through indicators such as having a visiting nurse service or needing a home health aid. Older people with certain personality characteristics, like a high need for control, a lot of need for autonomy, when you combine that with needing a lot of help, that can make functional impairment really distressing for someone. A lack of diverse coping strategies or flexibility, so having trouble coping with functional impairment. And as well, there's data showing that internalized ageism, so believing that later life is a time of disability, a time of suffering, is linked to decreased will to live. Next slide, please. Another thing to keep in mind is there's a lot we still need to know about the link between suicide and cognitive functioning. One piece of data that seems pretty clear is that if there is an association between increased risk for suicide and a dementia diagnosis, it's typically soon after the diagnosis and early in the illness. There's likely a lot of reasons for that, including that thankfully dying by suicide is very difficult to do. When someone's very advanced in their illness, dying by suicide may be more challenging, thankfully. It may also be a very stressful time to have that diagnosis. There's so much more we still need to learn in that area. But we can think about the time of diagnosis as a time in which older people may be particularly in need of intervention. We also know that cognitive control deficits, so being able to control behavior, slow down, that can increase risk for suicide attempts in later life. Next slide, please. Okay, so social disconnection. This is my passion. This is what I spend my days working on. And the reason for that is not that loneliness increases with age. It doesn't actually. Most studies show that younger people are more lonely, especially during the pandemic. The reason I focus on social disconnection is it's one of those 5 Ds that remains malleable throughout our lives. So I may not be able to help an older person I'm working with get rid of their functional impairment or their cognitive decline, but I can always help them increase their social connection. And in particular, social connection is actually a strength of aging. So by targeting it to reduce suicide risk, we are capitalizing on an aging related strength. People typically have greater relationship satisfaction in later life. And we know that social connections that create a sense of caring, of contributing, of community, they have a range of benefits for health and well-being across the lifespan. And what I have here are some examples on the slide on the left of indices of social connection that are linked to suicide risk factors, as well as suicide ideation, attempt, and death in later life in longitudinal studies, suggesting that they may play a potentially causal role. And you can see there are a diverse range of different indices of social connection that are linked to suicide risk that really gives us the sense of this is a really important construct. So many dimensions are linked to suicide risk. And what I also have up there is information from our prior Surgeon General who talked to us about loneliness and isolation as an epidemic that we need to be addressing. Next slide, please. So what we know about social disconnection and late life suicide, what I have up there are indices of that are linked to loneliness in later life, and you'll look at them and say, hey, Kim, those are basically the 5 Ds. And I say, yes, they are. So if we are able to target loneliness or isolation, any index of social disconnection, we're likely to be able to target suicide risk directly and indirectly by targeting all of those other factors. The other really key thing to know is that there have been 3 intervention studies ever worldwide that have shown effects on suicide deaths in older people, and all of them involve promoting social connection. But those studies weren't designed to test connection as the mechanism. So that's actually the premise underlying my lab. We're trying to do work to see, okay, if we move the needle on loneliness in later life, do we reduce suicide risk? So next slide, please. Okay, so turning now to the deadly means D and the 5 Ds, what we know about firearms. So we know, as I'd mentioned, that suicide attempts are more often fatal among older people, in part because they tend to use firearms. We also know that older people in the US who use firearms as their method are more likely to live in rural areas and to have served in the military. And I'd mentioned cognitive control deficits as a key feature of cognitive impairment that may play a role in terms of suicide risk. And when you combine that with a more immediately lethal means like firearms, we have an especially dangerous combination. So next slide, please. Okay, so I've gone through those 5 Ds. And so you can think about our role as clinicians as trying to tip the balance. So decrease the risk by decreasing those 5 Ds and hopefully increasing resilience factors so that we can shift the balance more towards resilience and helping our older people get on that normative development pathway towards emotional well-being and thriving in later life. The next slide, please. So I'm going to move now to suicide risk assessment. Just some overview of different strategies that are especially relevant to working with older people. So next slide, please. So briefly, why do we use screening tools? I've hinted at this. The goal of a suicide risk assessment is not a prediction about whether a patient will die by suicide. The reason for that is that thankfully, the vast majority of people who think about suicide will not attempt and will not die by suicide. We do not yet know the best questions to ask to know if someone will attempt suicide. So that can feel frustrating. But the good news is that we don't even need to do that in order to help keep someone safe. We can use our assessment to determine the most appropriate actions to take to keep a patient safe. So we need to take action for all endorsements of suicide ideation in later life, but not the same action for every endorsement. So next slide, please. So I'll tell you a little bit of what I mean about that. I want to keep in mind kind of what I see as the key components of working with older people at risk for suicide. And one is your attitude. So if you come in with a collaborative attitude, one of wanting to connect with your older patient and one of comfort in talking about these things, that's really essential. The other component is gathering information. So that's the asking questions part. That's only one piece of this. The other is making sense of the information and organizing it and synthesizing it. And that's the assessment piece. Fourth is taking actions while you're meeting with the patient. That might be something like creating a safety plan, as well as planning for follow-ups. And then there's fifth, taking actions after meeting with the patient. That's extending what you did and carrying it forward. That might be contacting the patient's primary care doctor. It might be scheduling a phone check-in for later in the week, those types of things. So your work isn't just when you're meeting with your patient, it's continuing outside and really keeping the collaborative relationship going. So next slide, please. So I'm going to return to those 5Ds and tell you kind of why I taught you all of that. So the goal of using the 5Ds in the suicide risk assessment is that it's a guide to help you take some appropriate actions to manage someone's safety right then. It can guide your treatment planning as well. So you can identify which of those 5Ds are most central to your patient's risk and suffering. And then you can work on those. They can help you guide you and figure out what are the things that you might want to do to reduce their suicide risk, in addition to any psychiatric diagnoses they might have. And so I'm going to show you what that looks like. Next slide, please. So I'm going to tell you a little about the questions you would ask, and then we're going to talk about how you would integrate that with the 5Ds. So one scale you may have heard of, and many hospitals, if you're working in hospital settings, are requiring that clinicians administer the Columbia Suicide Severity Rating Scale. I'm going to briefly talk about it. There are many different versions of it. The one I think that is most useful is a semi-structured interview. The reason for that is it's flexible. It gives you suggested prompts. The goal is to get the information that you need. It has additional questions. You don't have to ask the ones you don't need. While there is a self-report version, if you're able to do the semi-structured interview version, you're likely to get the most useful, clinically actionable information. So what's great about the Columbia? It includes worst point and many types of behavior. And the reason that's great is that worst point ideation and behavior is actually more predictive of suicide deaths than what you might get in that moment. So the day that they see you is likely somewhat arbitrary. And so having a full picture is really useful. The Columbia has standardized definitions for different types of ideation and behavior, and it has useful suggested prompts. So next slide, please. And so what I have up here for you is thinking about different ways that you can think about the different types of ideation. So thinking about suicide ideation from a spectrum of specificity. So going from thoughts that are least specific to most specific. And these are the types of ideation that you would assess in the Columbia scale. You can assess them outside the Columbia scale as well. So we've got passive suicide ideation, which is wish to be dead, moving to active thoughts of killing yourself, then having thoughts that include a consideration of method, and then thoughts that consider method with some intent to act, all the way up to intent with a specific plan, which is often an indication of imminent risk. The Columbia scale also has you ask about suicide attempts. Multiple attempter status is especially relevant for understanding risk, as well as other types of suicidal behavior, such as an interrupted attempt where someone starts taking action but is stopped by someone else, an aborted attempt where they take action but stop themselves, preparatory behavior like gathering pills, and non-suicidal self-injury. Next slide. So you do not need to read the details of what's on that picture. What I have here is just to give you a sense of what the Columbia scale looks like. And I am not someone who uses a lot of like hard copy paper, but doing the Columbia, I think printing out the scale is really very useful. So when I coach or teach people how to use this, I tell them to print it out. The reason for that is there's a whole lot of information on the scale that you can use to help you ask questions. It gives you definitions of the types of ideation. It gives you sample questions. And then it reminds you that you want to get information about the past month, that's in the right column, and you want to get lifetime, the time they felt most suicidal. When you get that information for every level of severity, you have a really good sense of someone's structure of their suicidal thinking recently and at its worst point. That's important because someone's suicide risk often waxes and wanes. That's common. So what they had in the last month is only one piece of the puzzle that we need to know about. So next slide, please. And so the next part of the scale talks about behavior. There's a lot of stuff on there, and once you get used to using this scale, you may not need to read all of it each time. But what's nice to have there is if a patient says something like, well, not really, it gives you some follow-up questions that you can ask. And so for here, you get behavior in the past 3 months and lifetime worst point. And so it takes a little bit of time, but I've actually done some work with my colleagues in our outpatient clinic that works with older people. And doing this and assessing the 5Ds doesn't actually take more time than a method that the clinic was using before. And so we found that actually this is actually just as efficient and maybe even more so than a lot of methods that clinicians had already been informally using. Next slide, please. Okay, if you do not want to use the Columbia Suicide Severity Rating Scale, it's not the only way to do it by any means. The PHQ-9, if that's an assessment measure you're already using with your patients to screen for depression, you can definitely have that be the foundation of your suicide risk assessment. And so what I have here is something that's called the P4 screener that was designed to be directly used with the PHQ-9. And so if you administer the PHQ-9 and someone endorses item 9, thoughts that they'd be better off dead or of hurting themselves, the P4 follows up with that and has some questions that you can ask your patient, and it gives you suggested actions to take. And so we have a link for you for that screener. It is free to use. And so it can be a nice way to sort of build off of what you're already doing. Next slide, please. Okay, so briefly, the evidence base for these actions. I want to say there are no clear evidence-based methods for preventing suicide deaths by asking certain questions, meaning there are no specific assessment batteries that if you use them, we know they will prevent suicide deaths. We don't have that yet, but there are clear best practices. So, like I mentioned, there are 3 randomized trials that have been shown to prevent suicide deaths in the world ever, but there's much more data looking at psychotherapies and collaborative care models and data looking at suicide thoughts and non-lethal attempts. And so there are things that we know can help. So next slide, please. So tips for asking about suicide. I have a couple up here. One is gentle persistence. So if your older patient says, no, not really, definitely want to follow up on that. Normalizing when people seem uncomfortable talking about it, letting them know that you want to hear it. And gentle assumptions. These do not plant seeds in people's heads. If you say things like, what other ways have you thought about killing yourself? It gives your patients information that you're open to hearing the answer. So next slide, please. All right, so risk management adaptations for older people in crisis. Remember what we started with. Suicide ideation is not normative in later life, even if your patient tries to tell you it is. Internalized ageism, in contrast, is linked to a reduced will to live and premature mortality. You also want to consider capability for suicide. So a lot of my work is on the interpersonal theory of suicide that breaks apart desire for suicide and capability. The idea that thankfully many people who want to die aren't capable of dying by suicide because it's very scary and it's very painful. But older people tend to die on their first attempt, suggesting that they may have more capability for suicide via methods such as drinking alcohol. That's less common in older people, but when it's present, it's very dangerous. Having a firearm in the home, executive dysfunction, and older people tend to have an over control of their emotions versus under control. So in an ED, an older person may seem very together and looks very different from a younger person. That older person who has themselves pulled together, we'd be much more worried about them at that point. We also know that older people are less likely to spontaneously report suicide ideation or reach out for help in a crisis. So what that means for me, I often do dialectical behavior therapy with my patients. With my older patients, I don't wait for them to call me for crisis coaching. We schedule a midweek check-in if they're having suicidal thoughts because I know that they're less likely to reach out to me. Next slide, please. Okay, so I wish I had tons of time to spend on this part of it, but I know we're reaching the end of our time. I'm going to give you some teasers about how we can manage and treat suicidal behavior in older people and give you lots of resources to keep learning. So next slide, please. Okay, so I mentioned this. These are the 3 studies that have shown effects on suicide deaths in older people in later life, and all 3 of them involve promoting social connection, which suggests to me at least that addressing social connection in our interventions is an essential part of how we can save lives. Next slide, please. So best practices, so indicated prevention, that means that's also clinical treatment. So essential is to routinely screen for depression and suicide risk. So you'd want to use a validated screener. I have some up there. The PHQ-9, the geriatric depression scale, the CESD or PROMIS are all measures that are validated for assessing depression in later life. You also want to screen for suicidal ideation and intent for those with depressive symptoms. That might be the Columbia Suicide Severity Rating Scale or the Geriatric Suicide Ideation Scale. If you're seeing someone in a clinical mental health practice, you likely want to screen for suicide risk in all of your patients, not just those with depression. When individuals are being treated in primary care, often there is kind of a triage, and you might be most likely to do that with your patients with depression. We want to diagnose and treat depression to remission. So not reducing symptoms, but getting to remission. And depression treatment is effective, including at reducing ideation, maybe suicidal behavior. Collaborating with your colleagues about appropriate psychopharmacology for your patients. Evidence-based depression treatment for older people, including problem-solving therapy, interpersonal psychotherapy. Older people who are seen in primary care being part of collaborative care models is a really good way to reduce suicide risk. All right, next slide, please. Okay, so suicide-specific behavioral interventions. Safety planning and some work I've done on something called connection planning, I think are very much best practices. They allow you to also include the family, address lethal means. You always want to make sure that older people know about 988. Caring contacts. These are interventions that have been shown across the lifespan to be associated with reduced suicide risk. Very simple, just connecting with people outside of a session. So scheduling a phone check-in. We want to address social determinants of health. So with my older patients, I'm always collaborating with my PCPs, and then hopefully you can also collaborate with agencies like our area agencies on aging, because they are experts at addressing those social determinants. Evidence-based psychotherapy for suicidal ideation and behavior can be a key part of reducing suicide risk in your older patients. And so that would be things like problem-solving therapy, a newer iteration of that, engaged psychotherapy, behavioral activation, interpersonal psychotherapy, dialectical behavior therapy, all of these acronyms. What I would suggest if you're newer to working with older patients, think about problem-solving therapy and behavioral activation. There are going to be links in the chats for you about how to get some training in problem-solving therapy and behavioral activation if you are new to them. They are treatments that work really well with older people. They're designed to help older people in particular, including those with cognitive impairment. All right, next slide. I think we're getting there. You guys have been hanging in there with me for a lot. So safety planning. Safety planning is best practice for suicide prevention across the lifespan. And what I have here is a wonderful resource that helps you provide safety planning for older people in particular. It's free, it's online. My colleague Liz Conti created it with the VA. There's a video that you can watch about how to do it. There's a free PDF you can download that walks you through how to do safety plan with older people. We also wrote an article, Dr. Conti and I wrote an article about safety planning that's linked to the 5Ds that's in the chat for you. So next slide. So safety planning isn't just about stopping someone from acting on thoughts, it's also about reducing their suffering. And so your safety plans can specifically address drivers of suicide risk in older people, including those 5Ds. So what we have up here is a paper that you can download for free and read. Sample things that can go into a safety plan that address the 5Ds. So if disability is a key driver of risk for your patient, you might address that in their safety plan. Another person might be disconnectedness. So these are very brief interventions that you can introduce early in therapy and start building on throughout treatment. Next slide, please. There are also ways to tailor your evidence-based psychotherapy for suicide risk, and I know we're getting close on time, so I'm going to go through this as kind of efficiently as I can for you all. You can use existing evidence-based psychotherapies for mental health to target the 5Ds. So for example, problem-solving therapy is you can be using that to solve problems around coping with disability. You might use interpersonal psychotherapy to navigate feelings of loneliness and grief for someone after losing a spouse. You might use behavioral activation to cope with depression after a new disease or diagnosis. You might use engaged coaching to get unstuck from the loneliness cycle and disconnection. So next slide, please. Okay, so I am gonna, I think, unfortunately skip this one. So go ahead to the next slide. We can come back to that if that ends up being something we have time to talk about. And this one too, I wish I could tell you about my kitties, but I'm running over. So next slide, please. If we have time, we'll come back and talk about engaged coaching because I think that it's a version of problem-solving therapy that can really increase hope. And it's what we're studying in my lab, but we're gonna go to the next slide. All right, so I'm going to briefly just tell you about the resources I have for you. Next slide. So you know what you're looking at when you go through them. So I have resources, all the resources about safety planning that I mentioned, that free article. There's a resource guide that can help you find community-based resources to target the 5Ds. You can download that for free. Next slide. And I've got some connection planning resources. So connection planning is just like safety planning, except instead of focusing on suicide risk, you're focusing on social connection. So I have some resources here if you want to learn more about that. They're all free and all online. Next slide. And what else have I got for you? So there we go. There's my lab. If you want to stay in touch, you want to learn more about engaged coaching, I invite you to scan our QR code and stay in touch with us. And that is what I have for you. So I will stop there and thank you for your time. And you can go ahead to the next references. Yeah, thank you. So the next
Thank
slide
you.
as well.
Yes, thank you so much, Dr. Van Orden. I now invite Dr. Westcott to give her remarks as well. Thank you so much.
Thank you so much. So I'm really here to speak very briefly, I'll keep an eye on time, about the role of counselors in this work specifically. And so I'll highlight that everything that Dr. Van Orden shared are strong, evidence-based, or at minimum best practice recommendations that can be used by any counselor on this call. So as a national certified counselor, my background was in clinical mental health counseling and specifically crisis intervention and suicide prevention. My research has been with older adult suicide intervention and prevention. And so what I would really like to emphasize for the little bit of time that I have with you is thinking about counselors' roles in those upstream factors that can contribute to death by suicide in later life. So counselors have a strong foundation in prevention and wellness frameworks. I was monitoring some of the Q&A and saw several of you speaking to your desire for us to speak about resilience and how that can be a support, which I think Dr. Van Orden did beautifully. So when I think about my recommendations for what counselors can do, I think the first thing is to notice warning signs even before somebody has reached the point of explicitly reporting suicide desire, or perhaps even before they fully have arrived at having suicide desire. So they're in those earlier stages of disconnection, depression, those factors that Dr. Van Orden was highlighting. Counselors are very well equipped to address those issues and support older people in finding social connection, in addressing some of those depressive symptoms and identifying effective ways of coping, in engaging in community intervention and finding resources to support things like disability. So I would really encourage counselors on this call to think about, what is your role in prevention? How can you notice these things in your older clients now that we're Medicare providers, and address them even before we get all the way to an older person having thoughts of suicide? When you are working with somebody who's having thoughts of suicide, I think it's important to recognize that the way that older people express those thoughts of suicide may look different from what you're used to seeing in your younger clients. And so you might hear people making references to feeling blue or feeling down or feeling really tired. And those are invitations for you to check in and ask about both depression and thoughts of suicide. And like Dr. Van Orden said, when someone says, no, not really, or something similar, I think we are talking about a time when we want to probe more and understand more deeply what's happening with someone. When I think about evidence-based approaches for working with older people broadly and how those might translate to supporting people who are at risk of suicide through prevention and intervention, one thing we haven't talked about yet is narrative reminiscence, which is a really strong theoretical foundation that many mental health providers use when they're working with older people. So helping folks connect with past positive memories or past challenges and make meaning of those experiences can be a really effective way to address depression and therefore help prevent suicide before we get to that place. We want to balance exploring positive factors, resilience, sources of joy, alongside acknowledging real challenges and how those may have manifested over the long term. I want to make sure that we have time for questions, and I want to make sure that we have time to hear from Kat. And so I'm going to pause my piece there, but I would be happy to answer any additional questions folks have, and I'll make sure that my email is included in any follow-up from NBCC. So I will pause and pass it over to Kat.
Thank you so much. I really appreciate all of the comments, and I can't agree more with Dr. Westcott and Dr. Van Orden's presentations. They were fantastic. From a systemic perspective, we think about what are the things that can increase our ability to be able to respond to an older individual. We want to make sure that we're creating and maintaining a system that's really going to be adjunctive to this work instead of taking away from it. So we think about what are some of the barriers for older individuals getting the help that they need, and for maybe what are some of the barriers for their support team or family members or partners to be able to intervene in a particular way. One of the things that we want to make sure of is, yes, there are logistical concerns to getting access. Maybe an older individual doesn't have the ability to be as mobile as they once were to be able to seek out services for whatever reason. But we can't exactly start with those logistical concerns, because it might be the case that those end up being excuses, right? Well, I can't get to this event because I can't drive, and my daughter or son can't drive me on that particular day. My child can't drive me, so therefore I can't get the help, right? Without other things being in place, those logistical issues kind of sound like defenses or excuses for why someone wouldn't support it. In another way, going back to the minimizing distress, that's really important as part of those 5 Ds. There's a lot of reasons why people would minimize the distress. I'm an older individual. I would expect to have some level of disease. I would expect to have a level of disconnection, right? I would expect to be depressed at this time in my life. And if a family member gets on board with also minimizing that distress, well, my parent is older, they can't track as well, right? Then we're really not providing a context or an environment that's supportive and adjunctive to care. And then finally, we want to continue to find ways to understand what the psychology might be behind someone maybe not helping, right? Is it hard for you as a child to think about your parent as being an older person who is vulnerable, if you've always seen them as someone who's maybe strong and competent and capable? And as part of you as maybe a younger individual, not the caregiver, not the person who's the older individual who's maybe having some of the suicidal ideation. If you have difficulty seeing your parent or someone older than you as being vulnerable, maybe that prevents you from being able to get them connected to the services, and you instead support their narrative about how difficult it is to get connected to services, or maybe how they have poor communication with health providers. Maybe you end up accidentally supporting the narrative because you psychologically can't kind of get on the same page that this older individual might have some needs that are pretty severe. So I will leave it at that and open up, I guess, the floor for questions if that's next.
Oh my goodness. Thank you, Dr. Van Orden, Dr. Westcott, and Dr. Hertlein for sharing your time, your knowledge, and your expertise today. This crucial information on how clinicians can help provide vital health care and reduce and prevent suicides in 2025 and beyond with the older adults has been magnificent. I'm astounded at how much ground we've covered. I feel like that we might need a follow-up webinar because there may be some things that are outstanding that we would like to talk about, but we'll get to that another time. We are going to move on and take at least a couple questions. We don't have too much time, but perhaps we can get through a few if you all are okay with that. One of the first questions that we had is it that the boomer generation brought in higher statistics of suicide rates, or is it possible that previous generations did not properly document suicide rates of, during their time due to stigma, the impact could have socially on family, et cetera, in the United States? And I think that's one for Dr. Van Orden.
Sure, that's a great question, and it's not an easy one to answer. I will say the United States has not great infrastructure for being able to address a lot of these questions. But I'll say very briefly, there are other countries that do a lot of very systematic surveillance of all types of health outcomes, including suicidal behavior. And we're not just seeing the trends in the US. So I would say there's likely any changes we see in suicide rates are probably driven by multiple causes. So I wouldn't rule out your hypothesis, which is a smart one, but I wouldn't say that the changes we're seeing are completely accounted for by that.
Very good. Thank you. Another question that has come in is, do you have any suggestions for encouraging social connection for clients who are resistant to change? And I know this one's probably hard to answer too.
Well, I would say first off that that's most people. It's social connection seems like one of those things that should be really easy to change, and it's actually not. If I'm working with a patient, I find that it's quicker to change depressive symptoms than it actually is chronic loneliness. So I would say that's actually the norm, and that really all of the interventions that I've done around social isolation and loneliness include kind of a motivational piece. Part of it, though, I will say the good news is that even just having a conversation about it and helping people understand that social connection is medicine. So just like you take maybe some pills in the morning, making sure that you're connected with people throughout the week is as important a part of your health as any other type of thing that you might do can be really powerful. And having people just say, I hadn't thought about that before can be really a really potent, very brief intervention.
Excellent. I hadn't even thought of that, but I love that idea. So thank you for sharing that. I think we have maybe time for one more question. We may have the speaker ask the speakers if they can answer some of these questions, and we could send them out to the attendees later on. So we will try to organize that as well. The last question that I'm going to ask is, what are the best practices for assessing suicide with individuals with Alzheimer's and/or dementia, if you can speak to that?
So that is a great question. I would say, first off, it definitely depends on the severity of the dementia. So if someone is at a stage where they're able to talk with you, the only real change I would say is make sure to include the family. So include the family, talk with them, get their collateral, and then get them engaged in the safety plan. Honestly, I would do that with most older patients. So I wouldn't just work with the older person, I'll work with their family member and I'll get the family member on board. The other thing is including the PCP, making sure the PCP knows about the safety plan, making sure you've talked with the PCP and understand the cognitive changes your patient is experiencing. So you can make sure that that safety plan is tailored to your patient's cognitive abilities. I think those are two straightforward, but probably the most powerful things that you could do for your patient.
Excellent. Wonderful suggestions. That is all the time that we have, so we're going to have to wrap up. The Medicare Mental Health Workforce Coalition and NBCC would like to thank Dr. Van Orden, Dr. Westcott, and Dr. Hertlein for sharing their knowledge and expertise, and all the participants for attending today's webinar. We have also provided a few slides with Medicare resources, including how to enroll in Medicare if you have not done that yourself as a clinician just yet. The link to the session evaluation is posted in the chat, and we're also going to email it to you following the meeting. The links that we posted in the chat that correspond with Dr. Van Orden's presentation will also be in that follow-up email, so don't panic if you were not able to catch those in the chat. To receive continuing education credit, you must complete the evaluation, including the attendance attestation, by April 17th at 5 p.m. Eastern Time. Certificates will be emailed to you by April 24th, and we're only able to provide credit for the live attendance of this webinar. We certainly hope you found this session informative. We look forward to seeing you again in the future. We will have an upcoming coalition webinar in July. On substance abuse, working with older adults and substance abuse. So we hope to see you then. Thank you and have a wonderful rest of your day.